Good morning, everyone. Thank you so much for being here, and welcome to the Johns Hopkins 2022 lung cancer event. My name is Dr. Christine Argento, and I am an interventional pulmonary doctor. My colleagues for this event are Dr. Russ Hales, who is the director of our thoracic oncology multidisciplinary program, or as some of us like to call it, the lung cancer program. He is our fearless leader. Dr. Joy Feliciano, who is a medical oncologist, and Dr. Rich Badafrano, who is a thoracic surgeon. We're all really excited to have the opportunity to talk with you all today. This event will last approximately an hour and a half. The first 30 minutes or so will be for us to give you an update on all of the exciting advances in our respective fields and specialties. And then the last hour, we're really excited to hold an interactive question and answer session where we would love to hear from you. We want to hear thoughts about what you've just heard and that we've just presented, answer any questions you might have based on what we presented, what you've heard about in your daily lives or what you've read about, and listen to any stories or any experiences that you have to share with us. This event, I don't know how many of you know, but has been going on since about 2008. And has gotten extremely popular over time. So it started out in a pretty small room, I just learned. And pretty quickly that room got to be way too small and had to be grown into bigger and bigger venues. Thankfully now on Zoom, it's sort of unlimited access, which is nice. But we're really excited to have you here. Every year it's been a resounding success. And I believe I'm not only speaking for myself, but also for my colleagues in saying that we learn just as much and get just as much out of this program as we hope that you will. Our patients and their family and friends, their support network are really what motivates us. And this event serves for us as a wonderful reminder of the vibrant community that we have both the pleasure and privilege to work with. And so with that, I would like to pass the stage over to Dr. Russ Hales, who will start off the event. And he will talk about protons, SABR, IMRT, Primeron radiation technologies.
Thanks so much. Appreciate the introduction and welcome. Thank you, all of you, for coming out and for being a part of our event today. For those of you who are patients of ours, you're seeing us without a mask if you've ever wondered what we actually looked like. For those of you who we haven't met yet, it's an honor to be with you today. And so I'll be focusing today on some of the basic technologies we use and perhaps give you a little bit of an under the hood look as to how these technologies work. Just want to start by thanking all of our veterans on this Veterans Day this year. Grateful for your service and for many of you that we help to serve and treat in the field of lung cancer. We're grateful for what you've contributed to what we can do in the field of science. So we're going to start today by really talking about four main topics: something called intensity modulated radiation therapy, something known as stereotactic body radiotherapy, and then we'll finish by talking about two newer technologies, proton-based radiation, and something that's very new called flash therapy. So what is intensity modulated radiation? Well, you can see in this image on the left that if this is the area in red that is the patient's tumor, in the old days, we would literally draw on a radiation field and we would send that straight through the patient's body, and that would accurately target the tumor, but it would also give similar dose to the patient's heart, which is just in front of the tumor. With intensity modulated radiation, we can send multiple beamlets of energy that all converge on the tumor and better spare some of the normal tissues. In order to do this, we give our team a list of variables or objectives that we want to meet. And I'll show that list right here. So this is a list of there's hundreds of variables, and all these variables are variables we're trying to meet. What more sophisticated radiation has allowed us to do is, instead of intentionally putting on beams and adjusting how they come in, we go from what's known as forward planning radiation to what's known as reverse planning. This is using supercomputers that use Monte Carlo algorithms that help us to find the best fit of hundreds of conflicting variables. We're trying to get full dose to a tumor while trying to entirely spare the heart that lives nearby. And we do that with these computational algorithms that involve penalty scores and cost functions. I certainly won't go into the math, but what that basically allows us to do is to create a very sophisticated radiation plan. As you can imagine, the quality of the plan then is a function of knowing the appropriate variables to use in each clinical situation. And so in essence, that's what IMRT, or intensity modulated radiation, allows. I'm now going to move on to something known as stereotactic body radiotherapy. This uses IMRT, but gives a very high precision radiation to a very small isolated target in a limited number of days, 4 to 5 days. This is low risk and highly effective. In this screen, you can see a patient's tumor in the right lung that's being targeted. And if we go to the next slide, you'll be able to see how we have multiple beams that converge on that area while sparing the nearby normal structures. Here's what results when we give this sort of treatment in 4 to 5 days. Before treatment, a tumor is left with a cavity after treatment. In this patient that I treated 10 years ago, this patient had a complete response and never experienced a recurrence of their tumor. So stereotactic body radiotherapy can be very effective. This is a study that compared this sort of radiation, also known as SABR, to what's called VATS, or surgery. And this looks at lung cancer specific survival for stage 1 lung cancer. And as you can see, between surgery and radiation, there was equivalent outcome. And so as I'll show you now, what we're using this technology for is for stage 1 lung cancer, as well as for patients who experience isolated progression in more advanced tumors. I'm now going to close by talking about protons. Protons allow us to bring radiation in, and the radiation dose deposits where the tumor is and has the advantages of no exit dose of radiation, whereas with photon radiation, the dose continues afterwards. What that allows is for situations that look more like this. You'll see a proton plan versus a photon plan in this next slide. And so you can see that with the photon plan, there's larger clouds of radiation around the area we're targeting. In this patient with a heart that sits right here, the proton radiation is better sparing the tumor. That means that the advantage is that there's less exit dose and less dose to normal tissue. But protons shouldn't be seen as a one-size-fits-all or something that is good for everyone. They are less resilient to tumor motion and to changes in anatomy. And so we only use this sort of technology in some of our patients. And perhaps in the Q&A, we can talk about when it's appropriate and when it's less helpful. Finally, I'll talk today about a technology known as flash radiotherapy. This is a very new technology. As I'll show you on the next slide, it delivers treatment approximately 400 times quicker than all of the other technologies I've talked about. So a treatment that may take 10 minutes to deliver with standard radiation can be delivered in less than 1 second with flash radiation. What does this allow? Well, we'll show on the next slide that although this isn't yet being used in clinical practice, there's active clinical trials, because when you deliver a very intense dose of radiation at a very quick moment in time, biologically, you get better sparing of normal tissues, and you need to worry less about the movement of the target because you're hitting it in a moment in time. As a result, what you'll probably find is a lot of exciting developments with flash radiotherapy in the next 5 to 10 years. This is something that really wasn't even being discussed just a year or two ago. And so in conclusion, in the field of radiation, we really have technologies that have led to fewer side effects and better tumor outcomes. Flash radiation may eventually transform the field of radiotherapy. And so really it's the collective kind of gathering or assimilation of these tools that are allowing us to treat patients with even more limited lung function so that they can safely undergo treatment. So in a nutshell, those are some of the exciting things that are happening in the field of lung cancer radiotherapy. Thanks.
That was wonderful. Thanks so much for that update. So next will be Dr. Feliciano, and she is going to give us an update in lung cancer with respect to medical oncology.
Thank you so much. And again, thank you everybody for being here. We really enjoy putting this on for our patients. I think it's one of our highlights where we really get to answer a lot more questions for our patients and really try to see many of the things that we're doing behind the scenes to try to improve the care of all of our patients. I'll go ahead and start with a couple of concepts that I want to bring up. This is a slide that I really like to show. I think I've been showing it almost every year now, and every year it gets extended. And what I really love about this is it gives us all a visual of how far we've come in really for a medical field such as oncology in a very short amount of time, relatively speaking. These are all of the types of medications and drugs that have been approved for different indications in non-small cell lung cancer since the early 2000s. And you can see every year we are continuing to add more and more therapies, more combinations of therapies, using our therapies in different settings to improve outcomes. And that's what's really been so exciting for us to participate in and to also be able to then use these therapies to help improve our patients' lives. It also, I think, points out that none of these types of advances could be done if we didn't do these in multidisciplinary groups. So all the faces that you see on the screen with Dr. Badafarano, Dr. Argento, Dr. Hales, usually when you have an appointment with one of us, it's not because only one of us is thinking about you. Usually it's a whole team approach where all of us are working together to think through, okay, what combination of therapies might this patient or their family member benefit from? Now, what I wanted to do is really just highlight most of the FDA approval. So those of you who have been on our lung event every year, I think I have mentioned the advances that we've made, but just wanted to point out some of the FDA approvals that we have gotten in lung cancer, and we as a collective lung cancer community since 2021. What you can see here is there's many drugs or there's different indications. So for example, immunotherapy with chemotherapy was just recently approved in patients who have resectable lung cancers. Atezolizumab, which is an immunotherapy, was approved after patients have resection of particular lung cancers. And then many of these you can see are approved in metastatic disease in patients who have very unique types of lung cancer. And that's something I want to emphasize. I think the first year I participated in this lung cancer event, we particularly talked about two mutations, which was ALK and EGFR. And those were ones that we were having a lot of advances in terms of therapies that could target those types of mutations. And now, as you can see, we've really been adding to that armamentarium every single year with different mutations identified and then subsequently different targeted therapies developed. Now, I kind of wanted to emphasize how we contribute to these advances. I'm very lucky to be at an academic institution where As I mentioned, we have such an incredibly strong interdisciplinary team. But I also want to emphasize that that interdisciplinary team isn't just the doctors. It includes our nurses, our gigantic research coordinating team, the advanced practitioners, and most importantly, all of the patients and the caregivers who trust us to be able to help guide you in treatment or help you participate in research. And really, if we didn't have these types of opportunities, I really don't know that we would be where we are today, but we still have a long way to go. So I'll end briefly with just a couple of examples of the types of research that we have. A lot of times patients come as an opinion to see, okay, what kinds of research can I participate in? Or if someone is getting treatment, they might say, is there any kind of research opportunity? And I think we do have many different types of research. Again, I want to emphasize that many of these are interdisciplinary. So here I'm only listing some of the projects that we have going on in our specific group of medical oncology, but there are studies in all of the divisions of radiation oncology, surgery, interventional pulmonary medicine. And so there's really many opportunities when patients are interested to get involved. Some of the studies I wanted to point out, in general, we have different classes of treatment that we use for patients with lung cancer. And specifically, when we are offering what we call systemic therapy or therapies that go throughout the bloodstream to try and kill or control cancer, we think of those in different categories. Some of those are standard chemotherapy options. Some of those are what we call targeted therapies, where patients may be identified looking at the genetic markers of their tumor itself and given a type of treatment that directly targets that marker. And then other types of treatment are called immunotherapy, which has gained a lot of use in the last 5 to 10 years, where treatments aim to get your immune system to be activated against cancer cells and kill cancer cells through your own immune system. And so some of the trials that I've listed here, as you can see, some of these are going to be based on the different kinds of mutations that a patient's tumor may hold. And then some trials, such as the Hudson trial, is a trial where patients whose cancer has progressed on previous treatments, including immunotherapy, might be eligible, where we're looking for ways to resensitize or to sensitize patients to immunotherapy, even if their cancer had previously grown on therapy. And then we have other types of interventional studies, such as the PCORI REACH study, where we are integrating aggressive supportive care and symptom management for all of our patients with advanced disease, because we know that doing that early for our patients can actually improve outcomes. We also have a whole group of studies that are not necessarily giving a new drug or giving a new treatment, but where patients can participate, such as biorepository studies, where we may collect or ask to collect blood or sputum or other specimens that we can later study in the future as we learn more about different types of cancer. And then we also have other types of ways to participate, such as survey studies, to really understand, what is life like for our patients who are living with lung cancer. So that concludes the updates I was hoping to give and share with our patients. Again, we've made a lot of strides with our systemic treatments. It wouldn't be possible without the collaboration with my other colleagues, but certainly not without the collaboration of our patients and their families. Thank you.
Thank you, Joy. That was amazing. And next will be Dr. Bottafrano, our thoracic surgeon, who will speak about surgery after neoadjuvant therapy.
Good morning, everybody. And again, I echo my colleagues and really appreciate you being a part of this. So when we talk about surgical therapy for lung cancer, what happens is that the increased utilization of CT scanning, whether it be lung cancer screening, or so many patients get CT scans as part of their overall care, we're picking up a large number of small lung cancers. And so the vast majority of our operations within our group are now performed minimally invasively. There are two ways to do it minimally invasively. Video-assisted thoracic surgery is essentially taking steps further with the equipment used for laparoscopic surgery that people are most familiar with. But the new advances there is that we now have, just like many of you have a 4K TV at home, we're taking advantage of that 4K technology to better see and better able to do dissections with the video-assisted technique. Now, many have heard the increasing use of robotic-assisted thoracic surgery, or RATS, and in that situation, they take advantage of a very sophisticated robot machine that has 3D visualization as well as robotic arms. And so there you have somebody at a robotic console, and then there are bedside assistants at the bedside to facilitate the operation. Next. Now, in our group, the minimally invasive approach is used for all of our clinical stage 1 lung cancers. And right now that represents about 80 to 90% of our stage 1 lung cancers are resected, completely resected, using minimally invasive techniques. Importantly, the outcomes, the oncologic outcomes are equivalent to historically open procedures, with decreased incisional pain and a more rapid return to resuming all activities. And that's important. And as we use other therapies after surgery, it's important that patients come through the surgery smoothly, get back to feeling strong in case they need additional therapy with Dr. Feliciano or occasionally with Dr. Hales. Now, the surgical and oncologic outcomes are actually equivalent with VATS and RATS, meaning robotic assisted. Each have their advantages and disadvantages. In our group, we've embraced both technologies. So two of our faculties, Dr. Stephen Yang and Dr. Jenny Ha, have embraced the robotic technology. Dr. Broderick, Dr. Bush, and myself utilize the VATS technology. Each have their advantages and disadvantages. And so whatever surgeons are most comfortable with are to the benefit of the patient. Now, as you heard from both Dr. Hales and Dr. Feliciano, we're using more of these therapies before surgery, what we call neoadjuvant therapy. And in these situations, the patients are chosen to be treated with upfront therapy or neoadjuvant therapy because their lung cancer is either relatively large or because these cancers are associated with lymph nodes that contain lung cancer cells. And we found over the years that historically, 25 years ago, we would take all these patients to surgery first, and then we'd regroup based on their pathology report. But what we found is that patients tolerate these therapies better before surgery than if we try to use them after surgery. So again, we're trying to take advantage of what we've learned as we've increased the abilities of medical oncology and radiation oncology to help us with our patients. So now what happens is the treatment of these lung cancer cells with either chemotherapy and immunotherapy together or chemotherapy and radiation therapy together. This is often associated with an intense inflammatory response that can make the dissection difficult. And so essentially, if we're going to remove a lobe of one's lung in order to take care of their lung cancer, by definition, it means we need to preserve the blood supply and the airways to the lung, part of the lung we're trying to save. And so in order to do that safely and effectively, sometimes we need to make one of our incisions bigger, which of course will be categorized as open surgery. But again, many of our incisions, even when they're open, are smaller than we would make historically. So this is an example of a large cancer that's adjacent to the bronchus here. You can see it's in the posterior aspect on the right side of your visual field, but you can see that tumor. And it clearly, in these cases, it's very difficult to try to get the whole operation done safely and effectively through a small incision with long, less sophisticated instruments. So on the next slide, you can see that this is active tumor. It's not just collapsed lung. and in the area where it's highlighted there, with the increased uptake on the PET scan. So these are the cases where we often will go right to open approach in an effort to make sure we get clear oncologic margins and also can do the surgery safely. Now, surgery after neoadjuvant therapy is associated with open incisions. So in our trials where we've looked at this carefully, 60% are completed with open incisions, but 40% are still able to be done with minimally invasive surgery. But one of the things that we've done as compared to 25 years ago is we're using smaller incisions and more incisions through the axilla, the armpit, which spares that large muscle on the back called the latissimus dorsi muscle. So again, by being able to perform these, even if the incision is open or classified as open, the fact is that their incisions are much smaller than we historically had done. And again, this is always performed so we can perform the surgery without bleeding. Often it allows us to complete a lobectomy and to avoid a pneumonectomy or complete removal of the lung. And then also when patients have been pre-treated, especially with chemoradiation therapy, we feel that the use of muscle flaps to cover the bronchial and arterial stumps is very important in order to prevent post-operative complications. So in conclusion, just overall surgery for lung cancers that require preoperative or neoadjuvant therapy, these are technically more challenging. However, through small but open incisions, we can often perform the procedures safely. And again, the pre-treatment, getting neoadjuvant therapy as compared to just getting adjuvant therapy is usually easier for the patients to take up front and has been associated with improved cancer outcomes for our patients. So we all work together, especially through the multidisciplinary clinic, to see people together up front, and then also to formulate a plan and integrating all the advantages from all four disciplines: medical oncology, radiation oncology, thoracic surgery, and also interventional pulmonary medicine. Thanks.
Thank you. All right. Well, I'm up next. So again, my name is Christine Argento, and I'm an interventional pulmonary doctor. Happy to be here, and thank you all again for joining. We really appreciate this opportunity. I think you're all here because we know that lung cancer is really a global epidemic. If you look at how many cases of lung cancer are diagnosed each year, it's almost 2 million globally throughout the year that are diagnosed. But then when you look at lung cancer mortality, it shows us that lung cancer is an even bigger problem that we really need to pay attention to. And so, you know, during Lung Cancer Awareness Month, we really want to get the word out about lung cancer, because although it's diagnosed really frequently, the fact is the mortality is higher than sort of the next most common cancers combined. So, you know, breast, prostate, and colorectal cancers. And so this is not encouraging, but thankfully we have a lot of encouraging updates, right? So we now are able to better treat our patients. But just to put it into perspective, because I think almost every one of us, you know, in the world, not just here on this call, right, is exposed to lung cancer. And so to put it into perspective, somebody is diagnosed with lung cancer every 2.2 minutes. And that statistic is really staggering. For me, I'm not as involved with treatment of lung cancer for the most part. What I'm really involved in is the early stages. So how do we diagnose somebody with lung cancer? And we're trying to get more people in for lung cancer screenings. We know the screening criteria have been updated recently. So within the last year, we're now able to screen patients who are between 50 and 80 years of age, who have a 20-pack year smoking history, and who have not quit smoking within the last 15 years. Or sorry, who have quit smoking only within the last 15 years, not further out. And what we're trying to do there is trying to diagnose lung cancers at an earlier stage, so before they become advanced. And what we know about lung cancer is that they don't tend to have symptoms when they're in early stages. And part of the reason for that is they tend to be on the periphery of the lungs. So if you look at this diagram, sort of the one on the right looks at lungs the way we typically look at them. And so a lot of early stage lung cancers are found in the very tip tops of the lungs. Or if you look at the cross section, which is depicted on the left image, you see that early stage lung cancers tend to be like right around the outside rim of the lungs. And those are the ones that are hardest for us to biopsy. And so it's harder for us to get an answer. And that's where some of our new technologies come in the interventional pulmonary realm. So when we're thinking about difficult to reach locations, we have several different updates, which I'm really excited to talk to you about. So the first one seems relatively easy. So most people have had some form of endoscopy. So whether that's a colonoscopy or an upper GI endoscopy, that means that you use a scope through a natural orifice. And in lung cancer, we think about bronchoscopy. So that's what I do. So that's taking a scope and it goes in through your mouth, into your airways, and we look around. And that scope can go in, be directed towards the lungs through the bronchial tubes. And you can then take biopsies of the lung tissue that way. Well, the bronchial tubes, they taper as you go towards the edges or the periphery of the lung. And so really what we've been limited by in a lot of cases has been just the diameter of the scope. It's thick. And so you can't get your scope out as far as you want to reach those areas in the periphery of the lung where those early stage cancers tend to be found. And so on the left, you see one of our more routine bronchoscopes where you can see it ends sort of in the middle of the lung, and then you have to extend your tools out towards the periphery, but then you don't have as much control about directing them exactly where you want to go, especially if you have a small target, as is shown in the chest CT, where you see that white little area is the nodule of interest that we're looking to biopsy. In the bottom left-hand picture, you see an ultrasound image, and you can see that there's this sort of darker area, which is what we're trying to biopsy, and it's sort of off to the side. It's really hard to target. When we now have, over the last couple of years, a lot thinner scopes. And so now you can see the scope that's going in on this X-ray, and you see it goes all the way out almost to the very edge of the lung. And so this allows us to be a lot more precise with our biopsies. Again, getting to a lesion that's right at the chest wall. And you can see on the ultrasound image, this darker area is sort of right in the middle of our view. And so it's a lot easier to biopsy and target. And it's not just about smaller scopes, but we also need better vision. So as we're doing our biopsies, sometimes we're using what's called fluoroscopy, which is basically a live version of an X-ray. So we'll place patients on a bed, and we use this X-ray technology called fluoroscopy to try and image as we're taking biopsies. If you look at the before picture on the top part of the screen, you'll see that you can't really see the nodule or the abnormality that the scope is sort of aiming towards and trying to biopsy. And so with augmented fluoroscopy, which is a newer technology, and basically we put a patient, we lie them on a board that has these little beads on it. And that's what these little dots are on the screen, on the picture. And then it takes these overlying images and puts them all together. And you see on the after picture, you can clearly see the lesion that we're looking to biopsy. And so again, so it's not just about having smaller scopes to reach those areas, but it's also having better visualization of the areas that we're trying to target that is helping us to move in the right direction. Next, as Dr. Botafarano talked about, we have also moved towards robotic therapies. So this is the robotic platform that we have at Johns Hopkins. It's called the ION, it's by Intuitive, and it gives us some really interesting things. What it does is we can create a pathway to our area of interest that we're looking to biopsy, and we control it with this hand controller, and the scope will move without us actually having to hold it. It stays really nice and in place, which is really good. It's steady for us to take nice biopsies. And it has these really flexible tools to go through it. So we will direct our scope and drive it to the area of interest, And once we confirm that we're in place, especially using this fluoroscopy or augmented fluoroscopy imaging, we then take samples with these newer biopsy tools, and we can mark our place so that we can go back. So here you can see there's a 1, 2, and 3, and that's sort of how we mark the areas that we've biopsied of this lesion. And so if we have a cytopathologist in the room telling us, you know, the sample was really good at area 1, but it's not as good at area 2, then we'll go and take whatever biopsies are needed from area 1. So again, this really helps us to shorten our procedure time, which is better for patients, and it helps us to get a better sample. And then there's been a lot of advances, and this isn't really pulmonary realm, but based on the biopsy samples that we get, there have been quite a few advances in how these biopsy samples are processed and what information can be gleaned from them. And so this is just a few ways that we do that. So if you look at the top left-hand side of the screen, that's 2 sort of typical slides that get made from the biopsy samples we provide. And on the left one, you see there are some tumor cells that are just that blue purplish color. And on the right-hand side of those slides, you see that there's a bunch of this brownish coloration or this brown staining pattern. And that is staining for PD-L1, which is a marker to say that your tumor may respond well to immunotherapy. And so there are several different stains that we can do based on slides like that. If you look at the bottom left-hand panel, you see this kind of weird looking image. It's called FISH, or fluorescence in situ hybridization. That looks for different gene rearrangements that we can find in different kinds of tumors that do respond well to some targeted therapies that Dr. Feliciano was talking about. And then in the whole right-hand panel of the screen, at the top, you're gonna see this kind of pretty image that's really looking at what we call NGS sequencing, or next generation sequencing, which is looking for all those genetic mutations that are very specific and individualized to each person's tumor or cancer. And that will tell us if there is a targetable mutation so that you can have targeted treatment, targeted therapy, whether that's chemotherapy or immune therapy or combinations thereof, that would work best to treat your specific cancer. And the pie chart on the bottom right hand of the screen is a little bit of what Dr. Feliciano had sort of presented, where it just sort of looks at the different mutations that we can find that have targetable mutations that are actionable. So it can really help to determine what kind of therapy is going to be best suited for you or your loved one. And this pie chart is changing sort of quicker and quicker. And it's very exciting to see how quickly this is moving forward. And so finally, I wanted to talk a little bit about intratumoral injection, which is probably one of the few areas where I am actually involved in the treatment of lung cancer. And it's something new that we are just starting to do. It's only available with clinical trial for now. But we basically take patients who have lung cancers that are accessible by bronchoscopy, and we will inject them with different substances, whether that's a chemotherapeutic agent, alcohol, immune therapy, etc. And we try to reduce the tumor size and treat it almost on a local level so that you don't have systemic effects of, chemotherapy that's either ingested orally or given through the IV. And so what you see here is a CAT scan on the top 2 panels. And you can see there's a tumor here on the right side of the screen, which is the left lung, really. So you see this big tumor here. There's the heart and the great vessels are above it, and then there's tumor below it. And then you see sort of the bronchial tubes. The one on the left-hand side of the screen or the right-hand side of the patient is open. The one on the left is actually blocked. And what we see on bronchoscopy, if this is the left bronchial tube, you can see there's tumor that's obstructing it there. So this patient underwent intratumoral injection, and you see that a month later, their scan looks very different. So you don't see that tumor anymore that's extending to the chest wall on the left-hand side. The bronchial tube is now open, both when you look on CAT scan and what you would see bronchoscopically. And so that's some very new and exciting advances for us. And so with that, I'll say thank you again for listening. And what we would really like to do now is sort of open the floor for question and answer period.
Thank you, everybody. And thank you, Dr. Argento, for your thorough review of the new technologies. What we're hoping to do now is be able to answer the questions that you or your family or friends might have. There should be a section on your screen where it says Q&A. And what you can do is type in your question there, and I'll be monitoring the questions and posing those to all of our physicians or myself as those questions come through. Okay, so we'll give you a little bit of time to go through, but and ask a question. But we do already have some questions, so I'll go ahead and get started if that's okay. So Dr. Argento, you mentioned how you do the biopsies and the different types of technology, but can you explain how you choose between those? And if you could kind of tell us, you know, in what scenarios might you choose one method over another versus a surgical biopsy versus interventional radiology, for example?
Yeah, so that's a great question, and it comes to us a lot, actually. And so really a lot of it is based on where is your nodule or your tumor located. So where is it easiest to reach? And basically we think about going from minimally invasive to more invasive. So minimally invasive, meaning we'd ideally like to have no cuts or incisions, no recovery time, outpatient procedures with minimal amounts of sedation. And we try to do all of that so that it's easiest on the patient and less risk of complications. And so if your tumor is most accessible with a bronchoscope, meaning it's more in the center of the chest, then it's definitely best for you as far from a complication standpoint to go at it with a scope from the inside than it is to get a biopsy from the outside. However, there are limitations, right? And so if you're on the periphery of the lung, the very top of the lung, those might be difficult areas for us to target. And then we start thinking about, well, is it better with a needle from the outside? Or we talk about this again as a group, and maybe Dr. Bottafrano is a better person to try and target the lesion that's maybe very small and very peripherally located. So it all depends what we're looking for. The other thing with bronchoscopy is we try to not just diagnose if you do have a cancer, but also to stage it. So it's really important to sample the lymph nodes as you're doing some of these procedures to decide how advanced or how early stage your cancer might be. And so that can all get done in one procedure if you do bronchoscopy.
Great, thank you. Dr. Hales, you mentioned proton therapy and that it has some advantages and disadvantages. Could you talk a little bit about when you choose proton therapy over other types of therapy and what patients might be good candidates for that?
Yeah, thanks for asking, Dr. Feliciano. So proton-based therapy is delivering radiation just like photon-based radiation is delivering radiation as well. For the rest of my response, I'm going to use the word X-ray to describe photon because the word proton and photon sound so similar. And so as noted, proton radiation has these unique advantages of when they hit the target, there's no exit dose beyond where the target is. And so in theory, you can better spare some of the normal tissues. And so we use this technology in patients who have tumors that are close to the heart, or especially in tumors that we are needing to retreat, patients who have had prior radiation in the past. As noted when I gave the brief primer, there are disadvantages too. Proton-based radiation is less resilient to changes. So if things are identical day to day, it can be very powerful and very effective. But those changes include movement of the tumor. They include shrinkage of the tumor or changes in the anatomy. If you take an X-ray plan and a proton plan and make any of these changes occur, the integrity and the quality of the X-ray plan is actually much better. And so we have to account for some of those things that I just discussed, movement of the tumor, as well as potential changes in the anatomy during treatment. As you know, Dr. Feliciano, we are all very committed to what we call evidence-based medicine. What that means to our audience is that we do things because studies show that A works better than B. And in a large study that compared proton-based radiation to X-ray-based radiation for many cases of lung cancer, there was no difference in side effects and no difference in tumor control. And so because of that, we need to proceed with caution in assuming that just because protons on paper can do something, that we should use it for everyone. Now, there were some limitations to that study. So there's a very large study being done right now to further explore this. And so I work with patients on a one-by-one basis to explore both technologies. A subset of my patients will be treated with protons and will have a benefit. But the other subset that isn't being treated with them are probably benefiting more from the X-ray based radiation. So as is the case in everything we do, it's really customized or personalized medicine that we try to use to determine which of these is best for the clinical situation.
Thank you. The next question, I think we'll go to Dr. Badafarano. You mentioned a little bit about what is robotic therapy or robotic surgery. Are there situations where it's better to do a robotic surgery? And how is that? And can you remind us again how that's different from a
So the robotic surgery for lung is pretty equivalent, and there's been multiple studies in which we've compared in our Society of Thoracic Surgery database. We look at those that are submitted for lung cancer cases that were done video assisted versus robotic. And so cancer outcomes, post recovery outcomes are all equivalent. Now, for tumors of the center of the chest, for instance, and not so much a lung cancer tumor, but a tumor of the thymus gland that sits right behind the breastbone and right in front of the heart, which is quite a narrow space. The robot has the advantage of seeing that better because it can get across the midline. So that's one advantage of the robot for thymic tumors. But for lung cancer tumors, we haven't really seen a huge advantage. One advantage of the video assisted technology is through the incisions, because they're placed in different strategic locations across the chest, you can actually palpate the tumor. So let's say it's not immediately visible when you're looking with the camera. What ends up happening is that you can palpate the tumor, which might be a half an inch below the surface. When you do the robotic the robotic ports, they're all placed posteriorly down by the diaphragm. So if you have a nodule in the top part of the lung, the upper lobe, you wouldn't be able to put your finger through there and palpate it. Now, one of the newer things that are happening in collaboration with the interventional pulmonologists like Dr. Argento and our surgeons using the robot is if they, at the time of bronchoscopy, can actually localize it and also sometimes use either dyes or something so that it would be visible even though it's below the surface. So then you could convert the disadvantage of not being able to palpate the nodule using the robot to now being able to see it. So we're trying to overcome those disadvantages, but each of the technologies, video assisted, especially with the 4K visualization and the robotic technology for lung cancer surgery has been equivalent so far.
Thank you. Okay, I think this question would probably be for me and Dr. Argento. A couple people have asked this, where if in the setting where your biopsy, whether it's by bronchoscopy or CAT scan guided biopsy, and there's not enough tissue for molecular testing or biomarker testing, what do you do and what accounts for that? And maybe you can start, Dr. Argento, and I can chime in as well.
Sure, that's a super, super frustrating situation. I agree with you, Ms. Collins, that that's kind of not the scenario that we hope for. We really do our best. So we try to mitigate those risks, just like Dr. Bottafrano was talking about. And so we'll have a pathologist in the room trying to give us some feedback on how cellular the specimen is, and do we have enough, they think, to perform all the studies necessary. When that doesn't happen, then we have to think about, again, where is this located? Do we have, should we rebiopsy in order to get more material? Or can you do other things like some blood work that might be able to give us similar information, but using blood work instead of going back to rebiopsy? And then finally, you can think about, we often will talk about these patients in a multidisciplinary format. So we talk about them on Wednesday mornings as a large group, where we can put our heads together and start thinking about, if they do need a repeat biopsy, should it be by the same service? Is there an easier way to access tissue? Or should we think about a different way to do that?
Thank you. And I was just going to add, I echo in the frustration. I know we don't want to be doing unnecessary procedures in patients, but sometimes the challenge is that either the location might be difficult, or if someone has, for example, a tumor that's very necrotic with a lot of dead tissue, for example, even before getting treated, those samples can be very difficult to run. Another challenge is that many of these molecular tests require a certain number of cancer cells. And so some of these samples might be okay for one type of test, but maybe not for the other. And so we really try to also, I think one of the people we haven't mentioned as part of our multidisciplinary team is our pathologists. They are hugely critical to how we perform the testing. And if, for example, there is minimal tissue, we work together to prioritize which tissue we might, which tests we might perform first. The other thing that Dr. Argento mentioned is blood-based tests or liquid biopsies, which have gained a lot of popularity for many reasons. First of all, just the ease of not having to undergo an invasive procedure, but it does have its limitations as well. Blood-based tissues test, blood-based tumor testing, although it's pretty readily available, it's more helpful in certain situations. For example, if you have metastatic disease, that might be a more helpful situation than if, for example, you have an early stage 1 tumor, because it depends on how much of those tumor cells are shedding into the bloodstream. The other challenge with blood-based testing is that it's not 100% sensitive, meaning in about 20 out of 100 cases where you may have a targetable mutation, for example, it will not pick it up in the blood. And so if we have a high suspicion of one of these types of mutations where you might have a target that we could use targeted therapy for, if the blood-based test is negative, it may still, encourage us to want to pursue tissue biopsy again. And part of the reason, again, we don't like to perform redundant tests. However, sometimes with some of these cancers, it is so crucial to know. That being said, another question that someone asked is, what do you do when we can't get those results? And if they're not, and if the blood-based testing is not revealing, then typically, we still have many therapies, particularly chemotherapy and immunotherapy, which is less dependent on those test results. And the hope is usually that at some point we will be able to get those tests, whether it's at the time if the cancer grows again or not. And sometimes it's just a matter of how difficult the location is to try to biopsy that tumor. Hope that answers your question.
Dr. Feliciano, you're muted.
Oh, I'm sorry. The next question would be for Dr. Hales, potentially. So could you speak about concurrent chemoradiation therapy for recurrent lung cancer?
Well, sure. Yeah. So some of you on the line may have had the experience of having been treated for lung cancer only to have a recurrence. And we always customize the therapy we give to the stage of the tumor, right? So if somebody has an early stage tumor, they really just need to see Dr. Botafarano and get a surgery, or myself and have radiation. And if on the other hand, the tumor is spread to other areas, they really need to focus on therapies that can go out throughout the body. And those are the sort of things that Dr. Feliciano is going to focus on giving. But in a patient who has a recurrence, there are some patients who have what we call a local recurrence, a recurrence just in the chest, and others who have a recurrence in more distant areas. In patients who have had a recurrence just within the chest, we can treat those patients with the standard therapy that we would give for newly diagnosed stage 3 lung cancer, and a subset of those patients will be cured. And so we do offer chemotherapy and radiation. In fact, our group published a paper really showing that in recurrent disease limited to the chest, that we can get outcomes that mirror the outcomes that we see in patients who haven't had a recurrence. And so the use of chemo and radiation can be very powerful. Now, let me just add a few other things. We can even consider this in patients who have had prior radiation, but this involves additional risk and comes down to an individual situation and their prior therapy. Lastly, even in patients whose tumors have spread, there are some patients whose tumors have spread to multiple areas and really need to focus on the sort of therapies that go throughout the body, like the ones that you offer, Dr. Feliciano. But there are some patients who have disease that's really just spread to a localized area, to one area, or who have one area growing and everything else is stable. And in those patients, there can be a benefit to them seeing somebody like Dr. Botafarano or myself to talk about a local therapy in that context. I jokingly tell our patients that the answer to all of the questions that are asked is it depends, because every situation is so customized and so unique. In that spirit, there may be a role for chemo and radiation in the context of a person's tumor, but it's down to multiple factors that we discuss with the patient and putting a personalized plan together.
In real estate, they say location, location, location. And in lung cancer, it's all about location, location, location. And that can be frustrating to patients because they'll say, geez, why did the 1 centimeter tumor need a whole lobectomy? And the 3 centimeter tumor was able to be removed by wide local excision. And it doesn't make sense when you read your reports, but when you look at the films, and one of the things we try to do with all our patients in those settings that can be confusing is to put the images up. Really, with the CAT scans are so clear now, it really takes, it's worth looking at the films together with patients and their families so they can understand why somebody they know got a little wedge for their tumor, and now all of a sudden you're talking about removing a whole lobe. So.
Thank you. Okay, I think Dr. Argento, this is a question around sort of screening as well as following lung nodules. You mentioned that right now screening is primarily for patients who have a significant smoking history. Is there emerging data on other populations who might also benefit from screening, or why is it only for patients with a smoking history? And then the other question related to that is oftentimes we'll see findings on a CAT scan that show, quote, ground glass changes And how do we follow those? Or
Good
what do we do with those?
Yeah, good question. So the first one is about lung cancer screening. And when lung cancer screening was first introduced, it was really based on a study called the NLST, or the National Lung Screening Trial, which looked at thousands and thousands of patients, and they sort of broke off the higher risk patients, and that became our criteria for screening because it showed a significant reduction in lung cancer mortality if you screen these patients. And so we were able to find patients earlier with lung cancer. And so that criteria was actually a little bit more stringent. It was harder for patients to reach. And through different studies, looking again, it was all based on patients as well as clinicians' observations that certain higher risk individuals were excluded from the screening criteria, that those criteria actually loosened. So now, instead of 30 pack year smoking history, we only require 20 pack year. The age actually got expanded from 50 down to 50 years old. You can start screening. And I think there's I know there's actually a lot of emerging studies out there trying to think about other high-risk populations and how do we include them in the guidelines. For now, it's really based on age and smoking status. But I will say that I think in the next couple of years, that's going to change, and we're going to start including more folks that are currently excluded from screening. I think we have a lot of work to do, and there's a lot of work happening in that arena. It's a really hot topic in research right now. So that's a really great question. The other question was about ground glass nodules, and those are super tough. Some of the things that we struggle with a lot. So ground glass nodules are sort of these hazy opacities that we see on your X-ray or on your CAT scan, meaning that they're not solid. So they're semi-solid. You can see structures underneath them, so you can see blood vessels or whatnot. And you know, they just look like little smudges essentially on your scan. And we don't always know how to interpret them, because that can mean it is a slow growing or very indolent lung cancer. So an adenocarcinoma that is not going to be aggressive. It's not going to grow very quickly. It, generally speaking, doesn't spread or cause any significant problems in the short term, but it can also represent infection, inflammation. And so this picture on imaging is very, very common. And so often what we do is follow those over time. And if they stay stable for up to 5 years or so, depending, again, back to Dr. Hales, who says everything depends, and it's all individual. So depending on your background and your history, if everything is stable after 5 years and you don't have anything else that would concern us that you might be developing a lung cancer, we may say that nodule is likely benign and you don't need to have any further follow-up. Otherwise, you will get a yearly CAT scan to follow that nodule. If it's changing, and when we become concerned, is either that it's growing at a faster rate than we would expect for a ground glass nodule, or if it's starting to solidify, that's when we start talking about your case again in our multidisciplinary conference to start saying, when would it be right to either biopsy this lesion or send you to somebody like Dr. Badafrano to remove it and make sure that we know exactly what that is. So these are some of the hardest things that we deal with, are the ground glass opacities. And it's a struggle, but we sort of follow our guidelines as far as timing of follow-up, but they tend to be longer follow-ups, which is a bit hard for patients really, because you're saying, well, I have this thing in me, why do I have to wait a year to get a scan? But generally it's because those don't tend to grow very quickly and they don't tend to cause a lot of problems. But it can be frustrating on the patient's part for sure.
Thank you. There's a couple of questions about small cell lung cancer and non-small cell lung cancer and what the difference is. I'd say this is maybe for me and Dr. Hales. If first we could go through sort of what are the big differences between small cell and non-small cell lung cancer, and then when do we use different types of therapy for small cell versus non-small cell lung cancer. I could start with the sort of main difference. Small cell is historically a very different kind of lung cancer than non-small cell lung cancer. The way it got its name is based on what it looks like under the microscope, and it's what we call a neuroendocrine tumor. It tends to be a type of cancer that starts in the middle of the chest, and because of that, it tends to be a little bit more difficult to diagnose. It's not usually seen on a chest X-ray, for example, and lung cancer screening has actually not been proven to be beneficial in detecting small cell lung cancer early. It also tends to be a type of cancer that behaves a little bit more aggressively or moves a little bit quickly. And so while it's not impossible to meet with someone like Dr. Badafarano to consider a surgery, and maybe he could mention the situations when that's considered, more often a person who's diagnosed with small cell lung cancer meets with both myself and Dr. Hales or myself alone, depending on the staging of the tumor. One caveat I'd say to this situation, and it was also related to one of the questions that another patient asked, is some patients can actually have a non-small cell lung cancer that then transforms into small cell lung cancer. That can be based on or related to certain types of mutations the tumor has. So for example, patients who have an EGFR mutation and other co-mutations, meaning other mutations alongside that EGFR mutation, might be at higher risk of their cancer transforming to a small cell lung cancer. And those cancers are treated similarly to our small cell lung cancers that are not related to EGFR. That being said, there's a lot of increasing research on whether or not, a small cell lung cancer that came from a different cell type versus one that starts off as small cell, whether or not those behave differently, whether or not we can prevent that transformation. And so there is a lot of interest in that area of those different types of small cell lung cancer. So maybe Dr. Badafarano, is there ever a situation where you would do surgery or this patient might be seen by a surgeon?
Yes, and I recently had a patient who 90% of the tumor, when it was looked at under the microscope, showed small cell, but 10% of it looked like squamous cell. I mean, when we call those tumors biphasic, that they're actually expressing two different histologies within the same nodule. And that nodule was quite small, so we originally felt that it was a non-small cell lung cancer. It was widely resected, including the standard lymph node sampling that we do. All the lymph nodes were negative for malignancy, but once we saw that it was 90% small cell, I took them back and completed the lobectomy in that situation. So if a patient has a smaller tumor, no evidence of cancer in the lymph nodes, no evidence of cancer anywhere else in the body, then the traditional approach would be to perform surgical resection via lobectomy, not a wide local excision. Then we work off the final pathology. Many of us feel, though, that they should go back and see a medical oncologist because we know the biologic behavior of small cells is so much more aggressive. So surgery alone probably isn't enough. Again, it depends, case by case basis, but for the most part, we think surgical lobectomy in that situation, even in the absence of lymph node showing cancer cells, we still would often recommend systemic chemotherapy for that patient once they've recovered from the surgical resection.
Thank you. Dr. Hales, when do you treat small cell lung cancer?
Yeah, thanks for asking. I think that just for the audience, and I just want to make sure that we're kind of giving wide principles here, because I think we're hitting on a lot of really important points that are also really unique. So for those who are listening in, two main types of lung cancer, small cell and non-small cell. 80 to 90% are going to be the non-small cell type, and 10 to 15% are going to be the small cell type. When we talk about a non-small cell cancer transforming into a small cell, some of you may have had that happen. That's a very, very uncommon event, and is so uncommon that I think it would be helpful for our audience to understand that that happens very rarely. In fact, just 10 years ago, you could write what's called a case report because it was so rare to occur. We now do see it occasionally, but it's a very uncommon event. So for those of you listening in, you should think of small cell as a sort of different type of lung cancer than non-small cell lung cancer. The key features are that while all lung cancers can have some risk of spread, small cell is the sort of lung cancer that has a very high risk of spread. So even if it's caught in its earliest stages, without the use of therapy to go throughout the body, like chemotherapy, patients will have a recurrence somewhere in their body. So even in stage 1 cancer, small cell tumors need to be treated with chemotherapy. There are lots of situations where radiation is used in small cell, both to treat tumors in the chest and to treat tumors if they spread to other areas. In fact, we even use radiation to sometimes decrease the chance of tumor spreading to some areas. And for those of you who may have small cell lung cancer, you can explore with your physician which of these situations would be appropriate for you.
Thank you. There's a question about, let me pull it down. A patient was asking about kind of interactions of systemic treatments with many of these medications. Can we combine them? Can we use them together or use them in combination with radiation? And so maybe I'll take a pass at that first question. So I'm a medical oncologist, and I give systemic therapies in patients where it's indicated. And there's many different unique indications for when you might need a systemic therapy. So systemic therapies are ones that get throughout the whole bloodstream. And there's broad categories of that, but in general, I talk about them in terms of chemotherapy or targeted therapy or immunotherapy, and they all behave or work in different manners. Now, sometimes people ask, well, why can't I just get all of them? Or shouldn't I get more than one? But we have to be very careful, first of all, because as we've talked quite a bit about, in patients with lung cancer, if we, for example, find a mutation, in many situations, a targeted therapy may be superior to, say, immunotherapy or chemotherapy. And so first of all, we want to use the best treatment for each individual type of patient. But another concern is that some of these medications do have interactions with each other, whether it's with other types of treatments or other types of systemic treatments or other types of interventions. And so an example I give, a question that comes up is often, someone may, for example, have a mutation called an EGFR mutation, and I may recommend a targeted therapy called osimertinib, but they've also heard about immunotherapy because there's ads on the football games, there's ads on billboards, and it is a type of medication that is commonly used now. The reason why, for example, we don't combine those types of treatments is that they can actually worsen and heighten the likelihood of a complication, particularly one called a pneumonitis or an inflammation of the lungs. There's lots of reasons that a patient can get a pneumonitis, but one of the dangerous kinds is one that can be precipitated by interactions of our medications or our drugs. And so we have to be very careful with our medications and think through what are the potential side effects. What are the side effects, not just with the other medications, but possibly other modalities of treatment like radiation, or what are the other complications that might be worsened based on a medical condition that you're also dealing with at the same time, such as an autoimmune disease, for example. So all of these types of treatments, the systemic treatments, we need to take into account what are their interactions and the potential complications with that. Okay, so the next question I will ask Dr. Hales. Does all radiation result in reduced lung capacity?
Yeah, it's an interesting question. The short answer that I would give is that anytime we give a therapy, there will always be some risks to the treatment, right? So in everything we do, there's going to be one step back before there's 3 steps forward. And when we give radiation to the lung that can be very sensitive to radiation, there can be an increased risk that the nearby lung tissue can develop scar tissue. So to answer the question directly, yep, there's always going to be some risk of that. The answer is a bit more nuanced, though. There are parts of the lung that have almost no function at all, especially in COPD. And in fact, surgeons will sometimes go in and remove the upper part of the lung because that lung is not functioning, and it creates a larger area for the normal lung to fill in and to exchange the gas that it needs to exchange. And so when we treat a tumor in the upper parts of the lung, the sort of scarring or fibrotic tissue that forms from the radiation actually shrinks that area of the lung that's not working and can actually help the bottom areas better expand. And so I have had patients I've treated that have actually had an improvement in breathing. For those who have had this SBRT therapy, the majority of those patients will describe no changes in breathing. And I've actually had some that will describe improvements. To be fair, some patients do also describe things getting worse. So it often depends on where we're treating, the overall state of the lung to begin with, and the technology that's being used.
And Dr. Hales, could you also, this may be related, can you also speak to whether or not you can get radiation in the same location, or radiation in the same spot?
Yeah, so getting back to that concept Dr. Bottafrano described of it all about being location, boy, that's really critical. If somebody's had prior radiation and that radiation is right next to, say, the heart, the risk of retreating is pretty high. If that area is out in kind of the periphery, the outside part of the lung, there's not a lot of those critical structures nearby. And so those patients can often be retreated. Often when we think about retreatment, there's really 3 to 4 factors we think about. Number 1, are there other areas of concern? Number 2, where is the location in relation to normal structures? And then number 3, what has been the duration? If somebody is coming back 3 months after completing treatment with a recurrence, radiation is probably not the tool you're going to want to go to. But if it's been years, that sort of tool can certainly be explored.
Thank you. Dr. Bottafrano, are there ever situations where surgery is used for metastatic lung cancer?
Yeah, that's a great question. Increasingly, the answer is yes. So if you had asked me that question 15 years ago, by definition, if there was a metastatic focus somewhere else, it wouldn't be treated with surgery. But what we have now is with the ability of either targeted therapy or immunotherapy to have completely stabilized disease or regression in many areas, there'll be some breakthrough in different parts of the patient's lung cancer syndrome, if you want to call it that, which everything's been stable for 3 or 4 years, but now there's been growth. And in those patients, we often, Dr. Hales and I will see them together and offer a discussion. You know, if it's too close to the main blood vessel of the body, the aorta, then it's going to tilt toward surgery. If it's in a good location for SBRT, maybe we'll tilt toward that. But the other area is that if a patient has metastatic disease, but we can't control a primary tumor, that is the person's coughing up blood and it's not being controlled either by radiation therapy or other treatments, or if the patients have developed an infection in that area. So where all of a sudden there's no good way to treat it. So it's very, very infrequent that we're called upon to use surgery for patients with lung cancer that has been metastatic. But again, with the beneficial effects of the treatments, if somebody's 4 years out from metastatic lung cancer that's been treated with immunotherapy or targeted therapy, and they have one slowly growing nodule, local therapy, whether it be resection with surgery or even treatment with SBRTs, very logical in those select patients.
So Dr. Hales, when are those situations that you use? And I can comment on a little bit too.
Yeah, I think that symptomatic tumors are certainly tumors that will use local therapy. I think the best answer we can give is that the information you're receiving today will almost certainly be different 2 years from now than it is today. I mean, that has just been where this field has gone. If you would have asked this question 5 years ago, we would have said in very, very, very rare situations would a local therapy used in a patient with a tumor that is spread or metastasized. I would dare say now that it's perhaps more common than not that patients will receive local therapy. And I bunch them into one of three categories. Number one, patients who have symptomatic disease or that need help to reverse pain or symptoms. Number two, patients who have limited metastatic disease, where if we treat the primary as well as the area that's spread with kind of a curative intent approach, we can often get better outcomes than we would with just traditional systemic therapy alone. And then number three, in patients who have tumor that's spread to multiple areas, but it's really working, being well controlled with the therapies Dr. Feliciano would offer. But now there's one or two areas that are growing. We can give local therapies in that setting and help prolong an otherwise effective therapy that's already being given. So those are kind of the three primary categories. Those categories seem to encompass many of our patients who have metastatic disease, though.
Thank you. And I was just going to add, both Dr. Botafarano and Dr. Hales mentioned patients who have either really well-controlled disease and then maybe one spot that grows where we might, again, on a case-by-case basis, and usually in the setting of our tumor board, discuss as a group, is a local therapy such as surgery or radiation something that we should consider? We do not have these particular studies, but that is an area of research that's very exciting right now, where patients who have limited metastatic disease or limited progression are being studied to see whether or not more aggressive local therapy approaches can continue to improve outcomes. And many of the studies so far have shown that there are certain, highly selected patients where local therapy may be beneficial. And Dr. Hales, did you have something else to add to that?
Well, I think that as we get to the end of this hour, I think that the one kind of final point I wanted to make was just this. Hopefully we've been able to show that there's a lot of exciting things that are happening in the field, but more directly, hopefully we've already shown just how nuanced the decision-making is. All the providers you're seeing join with 20 other providers as well that all work together to really kind of fashion the appropriate therapies for our patients. And what that means is that, the appropriate path forward is sometimes not so cookie cutter. And that's why we literally have integrated clinics where we're meeting hand in hand to help our patients.
Thank you. I think this will probably be our last question. I'm sorry, we probably can't get to every single question, but really appreciate the participation. This one, I think, will maybe go to Dr. Argento. Since you had mentioned, this is another lung cancer screening question, or risk factors. Are there other factors than smoking that we know of that are potentially contributing to the development of lung cancer?
Sure. Yeah, about 15 to 20% of lung cancers are actually found in patients who are not smokers. And so we know that there's a huge opportunity to look for risk factors. We know that secondhand smoke puts you at greater risks. There's some degree of family history that puts you at greater risk. We know, especially if you're a non-smoker, it tends to be, there's a gender bias there where women tend to be more affected. And then we think that there's a racial bias as well. And so there's lots of groups looking into these different risk factors to try and figure out how we can sort of plan and incorporate these things into our screening practices. It's a really, again, a really hot topic of debate. This lung cancer screening is sort of blowing up our research community right now in a great way. So hopefully, like I said, I think in the next few years, we're going to see some really big changes in our screening criteria for the better.
And I was just going to add, there was a recent study that was reported at one of our big European lung conferences. And I think this just speaks to how I think things may change in the next couple of years, but it was a study looking at the relationship of air pollution on development of lung cancer in patients who may have a genetic predisposition. And now this wasn't in patients, I'm sorry, this was in mice, but there is emerging evidence that people who may have a risk factor, it almost becomes that straw that breaks the camel's back and precipitates the transition to a lung cancer. So I do think as we understand the genetics better, and as we understand how the different risk factors interplay with each other, the lung cancer screening and earlier detection in all high risk populations will become more possible. So with that note, again, thank you so much to everybody who participated, and thank you to all the questions that were shared with us on the Q&A chat. If there is a question that we were unable to get to, please make sure that you talk to your providers. They're all able and willing to answer your questions that you might have about general topics or your individual cases. And we just want to thank you. It really is an honor to be able to do this, but more importantly, it's an honor that we are taking care of some of you and taking care with your family and your friends. And it really is an honor for us to do that. We feel so excited at how far we've come, but I hope you'll see that hope you realize we're working all so hard to do more and to get even farther. Thank you so much.
Thanks.
Thank you, everyone.